My name is Pooja Uppalapati, and this is a presentation on teratogens. The goals and objectives of this presentation are to review several of the teratogenic medications and social exposures that can affect fetal development. We also want to understand some of the medical conditions that can affect fetal development and describe the congenital anomalies associated with these exposures. What is a teratogen? A teratogen is any environmental factor that can produce a permanent abnormality in structure or function, restriction of growth, or death of the embryo or fetus. A dose-response relationship must be demonstrated between the teratogen and the effect, and we also need to know the time of exposure, the route, and the stage of pregnancy at exposure. Here is a slide on fetal development. You can refer back to this while we go through the lecture to see where the teratogen may have affected development and help you better understand some of the sequelae from the teratogen. As you can see, the organs develop pretty early on in the embryonic period, and the central nervous system actually continues to develop the entire time. So there can always be effects to the central nervous system. Genitalia are commonly later, as well as eyes, which can also explain why they are commonly affected as well. The first teratogen we'll talk about is called DES. DES is a test favorite, and while it's not currently used, it's still something that we encounter frequently in testing and should learn about. DES is diethylstilbestrol. It's an estrogen, and it's an agonist of the estrogen receptor. After many years, it's also been considered an endocrine disruptor. Initially, DES was given to women in the mid-1900s as a supplemental estrogen to reduce pregnancy loss. It was also used to treat breast and prostate cancers. However, there were many cases where women who had children after taking DES were noticing problems with their daughters and also with their sons. Many of their daughters were shown to have clear cell carcinoma, a vaginal tumor, which is not very common normally, and this was found to be linked. Because of this link, DES is no longer used. DES-exposed daughters are at an increased risk of vaginal epithelial changes, such as vaginal adenosis, which is when the cells from the uterus actually are present in the vagina, as well as an increased cervical transformation zone and uterine abnormalities, such as a T-shaped uterus. The uterine abnormality can also affect the fertility. So DES, while it does not affect the mother and didn't affect the infant initially, has long-standing effects. The sons of DES mothers also have an increased risk for cryptorchidism. Thalidomide is another test favorite and also another medication that is no longer used. It was a chemical that was used in the 1960s for nausea, especially morning sickness. The effects from thalidomide included limb reduction defects, facial hemangiomas, duodenal atresia, and cardiac defects, renal agenesis, and urinary tract abnormalities. Microphthalmia, genital defects, and dental anomalies were also seen. The defects directly correlated to development at the gestational age of exposure, just like when you look at that chart we have earlier. Thalidomide is believed to interfere with the neural crest-based sclerotomal organization. So during development, the sclerotomes make up the musculature, so it affects how they develop and how they spread from the neural crest. Thalidomide is also an inhibitor of angiogenesis and this directly correlates with its teratogenicity. This picture here is just an example of one of the limb defects you can see with thalidomide. PHENYLKETONURIA, or otherwise known as PKU, is also another test favorite. PKU presents in women who lack the enzyme to break down phenylalanine and can have high levels in their blood, especially after ingesting artificial sugar, otherwise known as aspartame. So phenylalanine can build up in the brain and decrease levels of other amino acids that are necessary for protein and neurotransmitter synthesis, and can also cause demyelination. Maternal PKU can lead to intrauterine and postnatal growth retardation, cardiovascular defects, and dislocated hips. Phenylalanine can and does cross the placenta and can build up in the fetus as well. A quarter of pregnancies in mothers with PKU will spontaneously abort. When the level of phenylalanine in the mother is greater than 20 milligrams per milliliter, there's a high likelihood of intellectual disability, microcephaly, and intrauterine growth retardation in the fetus. PKU is part of the newborn screen, which is every newborn that's born in the country has a panel of tests that are done right away, and PKU is something that's tested for. PKU is recessive. PKU mothers tend to have heterozygous children, so they might be phenotypically normal in regards to PKU, but they might have the birth defects that we just discussed earlier. Lithium is a commonly used medication in the treatment of bipolar disorder. With women who are on lithium who are desiring pregnancy, they should be counseled to avoid lithium in the first trimester of pregnancy if they can, and switch to a different medication regimen, and also try to abstain during delivery, as lithium has been shown to be correlated with low APGAR scores at birth. And lithium should also try and be avoided during breastfeeding. Exposure to lithium in utero can cause lethargy, hypotonia, cyanosis, poor feeding, poor respiration, and malformations of the central nervous system, the ears, the ureters, and thyroid. The most common buzzword with lithium is Ebstein's anomaly, which is one of the cardiovascular malformations you can see, and this picture on the right shows Ebstein's anomaly, and that can also be concomitant with tricuspid atresia. So in Ebstein's anomaly, the tricuspid valve, which separates the right atrium and the right ventricle, is much lower than it should be. This dotted line shows where the valve should be, and you can see the valve kind of flopping into the very small right ventricle down below. So this causes an atrialization of the ventricle, causes very large right atrium and a small right ventricle, and this leads to inefficient pumping of the heart. Mifepristone is what I'm going to talk about next. We're switching gears a little bit. Mifepristone is something that is used for medical abortion in combination with misoprostol, and it has been thought to cause birth defects, which we'll talk about. So mifepristone is also known as RU486. With misoprostol, it's very effective medical abortive in the first 49 days of gestation. Mifepristone works by blocking progesterone at the level of the endometrium and myometrium, and this causes contractions of the uterus. The rates of birth defects are actually pretty low with mifepristone when exposed in utero, and birth defects may likely be from use of misoprostol alone, not necessarily the mifepristone. Most issues with continued pregnancy after exposure to mifepristone are likely from the mechanical effects of contraction and not necessarily from the chemical effect of the medication. Women should avoid breastfeeding if they take mifepristone. There are some contraindications to taking this medication, and that includes ectopic pregnancy, an IUD currently in place, long-term corticosteroid therapy, anticoagulation therapy, or an inherited porphyria. After mifepristone is used in combination with misoprostol for a desired medical abortion, there should be a follow-up for confirmation. To follow up, after we're talking about mifepristone, we'll talk about misoprostol. So misoprostol is a synthetic prostaglandin E1 analog. Commonly, it's been used for gastric and duodenal ulcers, and it also is currently used for labor induction under the name Cytotec. Misoprostol can be used for medical abortion in combination with mifepristone, like we discussed earlier. It works by causing a transient drop in the circulation of the fetus via uterine hyperstimulation. Some studies show malformations in rats and rabbits to fetuses. Severe malformations have been reported in countries where misoprostol is used for abortion alone or without medical supervision. It's not very effective in medical abortion alone. It mostly just causes increased contraction and labor induction. The malformations that have been seen in humans include cranial nerve defects, especially pairs 6 and 7. This is something called Mobius syndrome, and there was one reported case of it in France under medical supervision, so that is something that could occur. And then various limb abnormalities can also occur, but are also very rare. The cranial nerve defects in Mobius syndrome are rarely detectable by sonography, so there's really not much monitoring you can do when there is continued pregnancy after using misoprostol. The next medication is methotrexate, also kind of in the line of medical abortion. It's formerly known as methotrexate. It's a chemotherapy agent and immunosuppressant. So it's currently used very frequently for autoimmune disorders, also for medical abortions, especially ectopic pregnancies. So methotrexate works as an antifolate. It competitively inhibits dihydrofolate reductase, which helps create tetrahydrofolate. So tetrahydrofolate, or folic acid, is necessary for purine and pyrimidine biosynthesis. So in a developing fetus, folic acid is extremely necessary. And this is also how methotrexate works as a chemotherapy agent and also as a medication used in abortion. Methotrexate can cause hepatotoxicity, ulcerative stomatitis, leukopenia in the mom, and is also teratogenic. As a teratogen, it can cause a multitude of defects, including growth deficiency, microcephaly, hypoplasia of the skull and bones, a broad nasal bridge, low-set ears, short limbs, and syndactyly. Pulmonary atresia and tetralogy of Fallot, which are congenital cardiovascular conditions, can also occur. Exposure between 6 to 8 weeks after conception with levels of 10 milligrams per week or greater are most associated with methotrexate embryopathy. So this brings us to folic acid deficiency as a teratogen in and of itself. So folic acid deficiency or antagonism can cause neural tube defects such as spina bifida and anencephaly, which means a lack of the brain. Periconception intake, it reduces the risk. So we always recommend women that are trying to conceive to start taking folic acid and build up their levels. Folic acid deficiency can also cause anemia in the mother, and you also would like to test for B12 deficiency, as they can often mask each other. Women with a previous pregnancy resulting in a neural tube defect does have an increased risk of subsequent affected pregnancy. This image right here just shows an example of a neural tube defect, in this case spina bifida. Valproic acid, VPA, is a commonly used anti-epileptic drug, usually under the name Depakote. So VPA can increase the risk of spina bifida, cardiac defects, cleft lip and palate, urinary tract defects, malformation of limbs, intrauterine growth restriction, and also low intelligence. So VPA does inhibit folic acid, just like we were talking about earlier, but it also inhibits histone deacetylase and changes gene expression. It also increases fetal oxidative stress. Many women can be on this medication for epilepsy or psychiatric disorders, so you would want to counsel your female patients to try and switch to a different medication if they are desiring a pregnancy, or to use contraceptive methods to avoid pregnancy while taking this medication. So next we'll move on to lead. Lead is commonly tested on the boards and also later on during pediatrics rotations. So lead generates reactive oxygen species and interferes with generation of antioxidants. So a woman with previous lead poisoning can actually still pass it on to her fetus, as lead is stored in bones and can be released many years later. Lead poisoning is considered a blood lead level of greater than 50 micrograms per deciliter, but most of the negative effects can be seen at greater than 20. Lead can cross the placenta at 12 to 14 weeks of gestation and accumulate in the fetus. Lead can cause spontaneous abortions and stillbirths. It can also increase the risk of hemangiomas, lymphangiomas, hydrocele, skin tags, and undescended testes. There is also a Vactral association. So Vactral is a group of symptoms and anomalies that tend to go together, and you'll see that a few of the teratogens in this list are also associated with Vactral. So The list here is below: vertebral anomalies, anorectal malformations, cardiac anomalies, tracheoesophageal fistula, exomphalos, so that's usually like a midline abdominal defect, renal anomalies, and limb anomalies. And the picture on the right is an example of a limb anomaly from lead poisoning. Next, we'll move on to obesity and diabetes. They're not necessarily considered teratogens, but they do have teratogenic effects and come into play all the time, so definitely should be discussed. Maternal obesity is associated with macrosomia, which is basically a big baby. Hypertension, preeclampsia, which is hypertension during pregnancy that can also have associated symptoms. Gestational diabetes mellitus, which is diabetes of pregnancy, and even fetal death. Uncontrolled diabetes can lead to persistent hyperglycemia in the mother and also periods of hypoglycemia. So hyperglycemia inhibits myo-inositol uptake, which is crucial for embryonic development during gastrulation and neurulation stages of embryogenesis. It can also lead to abnormalities in the arachidonic acid prostaglandin pathway, and this leads to growth retardation and neural tube defects. So the hemoglobin A1C can provide a marker as well. So a hemoglobin A1C greater than 11.5 is associated with increased risk of transposition of the great vessels coming off of the heart in the fetus, a ventricular septal defect, dextrocardia, anencephaly, spina bifida, and hydrocephalus. And again, there is a vectoral association with high blood sugars. The fetus or the newborn that is born can also have respiratory distress syndrome, hyperbilirubinemia, hypocalcemia, and vascular thrombosis. The next teratogen is actually hypothyroidism. Hypothyroidism in the fetus or in the newborn is usually when the fetal gland is suppressed by antithyroid medication that the mother is taking. So PTU, carbimazole, iodides, or maternal antibodies to the thyroid gland. During pregnancy, there is an increased requirement for levothyroxine, just based on how much of the hormone is actually available and how hormone-binding globulins are affected during pregnancy. So generally, the requirements tend to go up by 25 to 50% during pregnancy. There is an increased risk of anemia, placental abruption, preeclampsia, and postpartum hemorrhage in a mother with hypothyroidism. Congenital hypothyroidism was formerly known as cretinism. We avoid that term now. So congenital hypothyroidism occurs when there's maternal iodide deficiency and can have cognitive, neurological, and developmental abnormalities if not treated right away. Hypothyroidism is another thing that is commonly screened for in the newborn, just like PKU. You'd want to correct the hypothyroidism as soon as possible. Otherwise, some of these abnormalities can be permanent. Hearing loss is something that is associated with congenital hypothyroidism, and unfortunately, even with prompt treatment, it can be permanent. The infant or newborn with hypothyroidism may be asymptomatic at birth due to the crossover of maternal T4 through the placenta, but they can appear lethargic, have feeding difficulties, present with umbilical hernias, macroglossia, which is a large tongue, and also have a large forehead. So the image on the right is an example of a newborn with congenital hypothyroidism. The flip side, hyperthyroidism does also negatively affect the developing fetus. So hyperthyroidism during pregnancy is usually due to Graves' disease, which is autoimmune. So maternal effects of hyperthyroidism include heart failure, placental abruption, preeclampsia, and preterm delivery. The fetal effects are a goiter, intrauterine growth restriction, a baby that is small for gestational age, stillbirths, and thyroid dysfunction. Neonatal thyrotoxicosis can be seen, so it's basically a thyroid storm in the newborn. It's usually transient but can last several months, and the newborn will have exophthalmos, which is large, protruding eyes, tachycardia, hyperthermia, cardiac failure, hepatosplenomegaly, and hyperthermia. So an example of neonatal thyrotoxicosis can be seen in the pictures on the right. Alcohol is a very commonly known teratogen and something that is very commonly tested. As you can see from this very large chart, there are many, many, many effects from fetal alcohol syndrome, which develops when the mother is drinking during pregnancy. So we'll just touch on some of the highlights. So fetal alcohol syndrome is often seen in newborns that are born to mothers who are binge drinkers or drink heavily during pregnancy. The pathogenesis is that acetaldehyde inhibits DNA synthesis, placental amino acid transport, and development of the fetal brain. Genetic differences in alcohol dehydrogenase alleles in the fetus can make some infants more susceptible to alcohol levels in the mother, and no malformations have been documented if a mother drinks less than 1 ounce of ethanol daily. However, spontaneous abortion risk is 2 times higher with 1 ounce of alcohol twice a week. The recommendation is that there should be no alcohol during pregnancy. However, with unplanned pregnancies being so common, it is often unavoidable. So some of the most salient characteristics of fetal alcohol syndrome will be a very small baby that has very low adipose tissue. You'll see microcephaly, kind of a small head, small eye openings, microphthalmia. You'll see a smooth philtrum on the upper lip and a thin upper lip. So the image of that baby is on the right. You can also see strabismus, which is basically being cross-eyed. You can see ptosis, which is a drooping of the upper eyelid. You can also see ventricular septal defects, cardiac anomalies, hypospadias, which is when the opening of the urethra in the male penis is not located where it should be. You can also see hernias, so a little bit of the Vactral association as well. The next teratogen is tobacco. So tobacco is another social exposure that can be a teratogen. Nicotine in tobacco is a vasoconstrictor that results in uterine vascular constriction and intrauterine growth restriction because there's decreased perfusion to the fetal tissues. There's an increased mortality risk due to increased risk for placental abruption, placenta previa, spontaneous abortion, and prematurity. And placental abruption is when part of the placenta tears off and there can be a large bleed, as well as placenta previa, which is when the placenta is lying over an area where it should not be, and this can be harmful to the fetus. Carbon monoxide from smoke itself can cross the placenta and cause an increase in carboxyhemoglobin, and carboxyhemoglobin is not as good for oxygen transport capacity compared to fetal hemoglobin and can cause fetal hypoxia. The next teratogen is cocaine. The developing fetus cannot metabolize cocaine quickly as it does not have much plasma cholinesterase. Cocaine blocks the presynaptic reuptake of neurotransmitters at the nerve terminal, leading to elevated levels of norepinephrine and dopamine. These in the adult with high levels of norepinephrine and dopamine that are sustained can cause psychosis. Calcium homeostasis in the fetus can also be disrupted due to cocaine. Cocaine is also a vasoconstrictor and can cause vascular disruption, leading to placental abruption, cerebral hemorrhage of the fetus, intrauterine growth restriction, limb defects, bowel atresia, and necrotizing enterocolitis. There is a higher risk for prematurity, for microcephaly, and sudden infant death when a mother has been using cocaine. The next medication we'll talk about is isotretinoin. So most people commonly know this as Accutane. So there is a 25% risk of fetal abnormality when using oral Accutane, retin-A, or retinoic acid. And again, this is oral. There hasn't really been shown to be any effects for topical formulations. The critical exposure period is with between 4 to 10 weeks of gestation. And pregnancy prevention has to be emphasized with women of reproductive age that use these medications. You'll often see pregnancy contracts with women before they start this medication, as the risk of fetal abnormality is so high. This table below just discusses some of the fetal abnormalities that can occur with using medications like Accutane. And again, it's a lot of that bacterial association, the craniofacial abnormalities that you see in many embryopathies, including low set, small malformed ears, a small head, epicanthal folds, low nasal bridge, etc. The next teratogen is radiation. So ionizing radiation can injure developing embryos due to cell death and chromosome injury. The critical window for this teratogen is 8 to 15 weeks after fertilization, and women should avoid exposure as radiation is not likely to be lethal to the fetus but will have lasting effects. So you'll commonly see that if a young woman or woman of reproductive age has to get some type of x-ray or MRI or CT, they will always be asked if they're pregnant to avoid exposure. The central nervous system is the most sensitive to radiation, and like we discussed before, central nervous system development occurs throughout the entire pregnancy, so you should avoid radiation at any point during pregnancy. In utero, radiation can cause microcephaly, so small head, intellectual disability, along with increased incidence of hematopoietic malignancies and leukemia in the future. The next teratogen is warfarin. So women with thromboembolic disease, artificial heart valves, often need long-term anticoagulation and will often be on warfarin or some other anticoagulation. Warfarin is the most studied as a teratogen. So warfarin inhibits the formation of carboxyglutamyl from glutamyl residues. So there will be an inability of proteins to bind to calcium. So there will be unbound calcium in fetal circulation. So the critical period of exposure is 8 to 14 weeks of pregnancy. The unbound calcium in the fetus during ossification can lead to many bony abnormalities, including choanal stenosis, stippling in the tarsals and proximal femurs, and paravertebral processes. You can also see small nails and short fingers. There can be ophthalmic manifestations, including optic atrophy, blindness, as well as visual impairment. The picture on the right shows one of the bony abnormalities in the face that can be seen with warfarin. ACE inhibitors are the next teratogen. So ACE inhibitors are commonly used for blood pressure control. Captopril is one example. Captopril can cross the placenta. So ACE inhibitors are associated with spontaneous abortions, intrauterine and neonatal deaths, and neonatal respiratory distress. Limb and central nervous system defects can be seen, as well as a heart defect, including patent ductus arteriosus, oligohydramnios, which means low fluid around the fetus, and renal tubular dysplasia. The proposed method is that ACE inhibitors inhibit fetal urine production and also inhibit the renin-angiotensin-aldosterone system. You'll see this as a problem beginning in the second trimester. So generally it's been considered ACE inhibitors could be used in the first trimester if necessary, without any lasting effects. ACE inhibitors have also been implicated in aortic arch obstructive malformations. Statins are our last teratogen that we'll discuss. Statins inhibit the HMG-CoA reductase, which forms mevalonate from HMG-CoA in cholesterol synthesis. So we're going all the way back to biochem here. Cholesterol is an integral part of cell membranes and is a precursor for steroid hormones and hedgehog signaling. Statins are in category X for pregnancy, so they're contraindicated in pregnant women. There's actually been no studies that directly show teratogenic effects of statins. However, we do know from some other diseases that a cholesterol deficiency can be disastrous to a developing fetus, so the risk is too high and the use of statins are not recommended. So diseases with decreased cholesterol synthesis, one could be Smith-Lemli-Opitz, shows infants with microcephaly, so small brain, small head, facial abnormalities, micrognathia, so a very small chin, strabismus, cataracts, slanted and low-set ears, syndactyly of the second and third toes, polydactyly, hypospadias, cleft palate, cardiac defects, and pulmonary abnormalities. So the picture on your right shows you what an example of the syndactyly of the toes can look like. In this case, this would be with Smith-Lemli-Opitz, but is also proposed for what statins could do. So thank you very much for your attention.